Welcome everyone, and thank you so much for joining us today for this seminar on the experiences of women with kidney transplants, as well as understanding the sex and gender disparities in access to transplantation. This is a very important and timely topic because there's growing evidence to suggest that there's high persistent inequities in access to transplantation, waitlisting, living donation, and outcomes across the many settings worldwide. And addressing these disparities requires not only better evidence, but also open dialogue, collaboration, and leadership with our patients, our key stakeholders, our clinicians across the globe. Today's webinar brings together colleagues from around the world who are really committed to advancing equity in transplantation and improve our understanding in terms of women's health post-transplant. I'm hoping that through such discussion, we will raise awareness, improve our understanding, and identify opportunities to move the field forward. It is also my great pleasure to introduce Dr. Bianca Davidson from South Africa, the inaugural chair for Pillar 3 of the Women in Transplantation, who played a key role in advancing leadership, mentorship, and advocacy initiatives to support women in transplantation globally. Over to you, Bianca.
Thank you, Germaine, for that kind introduction. I'm truly honored today to be with this amazing panel of women that you will hear from. It was my honor to be the previous chair of WIT Pillar 3, and what better place to start advocating for women than to going back to the women that received the kidney transplants and find out what their barriers were to accessing care. So to start the talk off today, I'd like to introduce Dr. Maleeka Ladhani. She's a nephrologist who more recently trained as an obstetric physician and practices in Adelaide, Australia. She has research interests in gender discrepancy, and that is how she became part of WIT Pillar 3. She works both at Lyell McEwan Hospital and Flinders. Over to you, Maleeka.
Thanks for that introduction, Bianca. It's been a pleasure, as you said, to work with Women in Transplant Pillar 3. Before I begin, I just want to acknowledge the traditional owners of the land and pay my respects to elders past, present, and emerging. Before I continue, I just like to let you know what our aims were for Pillar 3. We were meant to increase awareness in the transplant community around gender disparity, particularly in living donation and access to transplant in women, and create educational content for patients, caregivers, and health providers. And as part of that, our group thought that it might be a good place to start to get evidence around the experiences and perspectives of women who had kidney transplants. So that was the way that this project came about. So moving along with the project, as you know, and Germaine alluded to, women are more likely to take longer to be waitlisted for a transplant. They're less likely to receive a kidney transplant, and they're more likely to donate one. And these discrepancies, whilst there are some biological factors related to that, can be exacerbated by culture and income. There are also specific to women issues that are impacted around transplant and kidney disease, like women's health and family planning. So the aim for this project was to describe the perspectives and experiences of women with kidney transplants in different cultural resource settings on access to healthcare through their transplant journey, with a focus specifically on women's issues, including menstruation, parenthood, and fertility. We did this by purposefully sampling across different income countries, women with kidney transplants who were 18 years plus. We did semi-structured interviews, usually online, from August 2022 to 2024 until we got data saturation. And these interviews were conducted in 3 languages, English, Tamil, or Spanish. We used Hyper Research as our software, and our thematic analysis was done by 3, myself, Nikki, and Alison Tong. In terms of our who was in our the demographics of the women in our groups. We had 40 women who came across 16 countries between ages 18 to 70. The most of the women were between 41 and 50. Over 50% were from high income countries. Of note, we weren't able to access as many lower income countries, which I think was partly related to how we were conducting interviews, but also speaks to some of the issues around transplantation in that group. Most women had living donors, and we got a nice spread of women across those who were menstruating, who were 40%, some who were perimenopausal, 10%, and some who were postmenopausal. Not everyone had pregnancies. Some had pregnancies before their transplants, and some had pregnancies after their transplant. As I mentioned, there were different languages spoken for the interviews. Some women were, so about 50% of women were employed. Some were part-time studying, retired, or unemployed. The majority of the women interviewed had a bachelor's degree or higher. And there you can see the length of transplantation in the graph there. Once we had established the thematic analysis, we came up with 4 themes that came across strongly. And these were, more generally, women were frustrated by the limitations of the healthcare system, and more related to women's issues, they found that they were struggling to achieve parenthood. There were some stigma around gender-sensitive topics, and there was a social vulnerability which exacerbated their barriers because they were women. Now, from here, I'm going to spend a couple of minutes on each of these themes and go through the sub-themes, including some quotes surrounding these. So moving to being frustrated by the limitations of the healthcare system. Within this theme, there were sub-themes of feeling disempowered by lacking information, unresolved distress, being exhausted from self-advocating and organising logistics, and a feeling of women being without continuity and their care not being cohesive. Some quotes around being disappointed by lacking information was from a woman in a high-income country. Everything was presented from a very medical perspective. I felt very alone, and I asked, and they told me, don't ask. A sub-theme of unresolved distress, a quote that supported this was, you had your physical needs met, but that psychological support is really not there. One particularly interesting response to, and within the sub-theme of being exhausted from self-advocation and organising logistics, was this following one from a woman who had an experience during her pregnancy. They lacerated my kidney transplant in the cesarean. They were all panicking and they didn't actually really know what to do. I said, I need you to call the head of nephrology and urology. I need you to call them immediately, and then I need you to knock me out because I cannot handle this stress. Another sub-theme was lacking continuity and cohesiveness of care. It'd be nice if there was someone who would focus on me, kind of as a person, and not just, I go to this person and I'm a kidney, and I go to this person and I'm a uterus. As you can see, we had some quite strong responses, which gave us quite a lot of rich information. The second sub-theme that we're going to talk about was stigma around gender-sensitive topics. And the sub-themes for this one were unprepared. Women felt unprepared for changing body image. They felt a loss of intimacy and femininity. They felt shame of seeking mental health services, burdened by unexpected continence challenges, unforeseen menstrual changes, and the devastation of having HPV. Some quotes related to these were, I've got a lot of facial hair and very chubby cheeks from the prednisone and incredibly thin skin. One particular participant said, the hospital should make it compulsory for you to visit a psychologist. It's so taboo. The idea of going and talking to a psychologist, it means you're mental. which demonstrated her shame of the feeling of shame going to seek mental health services. There was a burden related to being unexpectedly challenged by continence issues. I had to catch public transport to get to the hospital. I had to get off the bus 3 times to go to the toilet to get to the hospital. And some issues around unforeseen menstrual changes. My issue is every time there's a diagnosis, we're not sure if the cause is hormonal or if it's related to the kidney transplant. Moving on to the third theme, we found that women were struggling with their ability to achieve motherhood. Within this theme, there were sub-themes of confronting irreversible consequences, grieving lost opportunities for parenthood, medicalization of the journey to motherhood, and avoiding burdening children. One participant said, the doctor said, I don't think you need to be doing a lot of this relating to being pregnant. So I had one and done. Another participant said, that is what they told me. Don't even think about getting pregnant. It is ruled out, and hence was grieving a lost opportunity for parenthood. Another quote here around medicalization of the journey to motherhood was, it was great until the end of my pregnancy. I had preeclampsia and my son had to be evacuated. He was teeny tiny to me. I've never held a child that was only 4 pounds. Another sub-theme for that theme was avoiding burdening children. Mothers particularly felt bad about the effects on their children. It affected her for like 13 years. When the kids were at school, they'd bring something home and I'd go down like a ton of bricks. And she thought I was going to die mostly. And the last theme here is that of social vulnerability exacerbation leading to barriers for women. And in that theme, we had sub-themes of being forced with financial dependence and fear of relinquishing decision-making. And a couple of quotes related to this include, I was very young and my work didn't give me insurance, but my brother had insurance. By the time I came to my second transplant, my husband had put me on his office plan, which demonstrates that this woman was dependent on both her male relative and her partner for her finances. There was also a fear of relinquishing decision-making. With this quote, I understand the hospital process. In some ways, you lie down and you give your body over, especially for the transplant. So coming back now to the thematic schema, you can see there are a large amount of information that we got from these women that had quite a lot to share about their journeys. And one of the things that might actually help demonstrate these journeys further is to talk about the journeys of other women who have received transplants. So I'm going to hand back to Bianca to introduce the rest of our panel.
Great, thank you. I'm truly honored today to have two patients and Zibya with us. I'm just going to introduce everybody quickly. So Dr. Zibya Barday is a nephrologist who works at Groote in Cape Town, South Africa. She has a keen interest in transplant and runs our amazing young adolescent health service. She's joined today by our patient, Robin Bashley, who will be telling us a little bit about her journey with transplantation and barriers that she found. After that, we are also very blessed to have Nikki Scholes-Robertson with us. She's a kidney transplant patient who has had a kidney now for 11 years. It was donated by her younger brother. She's also part of the research team that worked on this project. She's a physiotherapist and she's a researcher who is primarily focused on equity and access to healthcare, and she's also based in Australia. Zibya, I'm handing over to you.
Thank you, Bianca, for that wonderful introduction. It's my privilege to introduce Robin Bashley, who is a remarkable patient in our kidney transplant unit at Groote Hospital in Cape Town. I first met Robin when she was pregnant with little Gracie. And what struck me about her story is the strength that she carried throughout that journey. And I'm going to briefly walk through her medical journey by way of introduction. So in 2011, Robin was first diagnosed with SLE at the age of 17, and she had lupus nephritis class 3 with hypertension. She was on immunosuppressive therapy and developed a chloroquine maculopathy, so she's got some residual visual impairments. And at the clinic, she got quite a bit of support in terms of counseling on reproductive health, including contraception. In 2019, her kidney disease progressed and she reached end-stage kidney disease, requiring hemodialysis, and then she was later switched to peritoneal dialysis. 4 years later, at the age of 28, she received her first kidney transplant. It was a live donor from a friend. And during that transplant, she got basiliximab induction with maintenance therapy of MMF, tacro, and prednisone. And during that admission, her MMF was switched to azathioprine due to GIT side effects. But when she was discharged, her graft function on discharge was about 130 with the eGFR 47. 3 years later, she had a planned pregnancy. They removed the implant contraceptive device and she successfully conceived. And at the time of pregnancy, her graft function was stable. She had no proteinuria and her blood pressure were controlled. And there were no extrarenal manifestations of her lupus or flares. And during pregnancy, in the middle of her pregnancy, she had suspected preeclampsia with a rise in creatinine. She got betamethasone and she had a cesarean section and delivered preterm at about 30 weeks gestational age with little Gracie, who was 1.5 kilograms at the time. And I'm very happy to welcome her and Gracie back to the Transplant family and just hand over to Robin with her story. They can see you.
Hi everyone. I don't have much to share that Dr. Barday has already told you. So as she mentioned, I was diagnosed with SLE at the age of 17. And at that time, I didn't have a lot of knowledge about what SLE was because nobody in my family or my friends had any diseases like that. And there wasn't much research that I could do regarding that because I didn't understand that as well. But I took it as it came, took my medication, came to my doctor's appointments. And then as time went on, I grew to love with it. And then as I grew older, I became accustomed to it and it was just part of my daily life, just knowing that I need to have my breakfast, take my medication, do my schooling. At about 19, I started working. So that also had a huge impact on my work. And also, it took me about 2 years to fully adapt into a working environment without having any side effects or needing to go constantly to the hospital. Because in the workplace, not everybody understands what you're going through, especially with something that they don't really understand. Because if you tell somebody, I'm diabetic, I've got cancer or some sort of that thing, they would understand because it's something that they know of. So it was quite tough, with friends and going to places where you can't go because you're very restricted. Got a medication time, you need to do certain things, you need to eat certain things, and your body weight also plays a huge impact. I heard you mentioned earlier that one of the ladies that you did the study with says about the chubby cheeks of the pregnant zones. So that is something I also struggle with a lot, which I'm very conscious about. But that is also what I'm working on because at the end of the day, the pregnant zones is helping me. And this is just another side effect that I have to live with and accept. So I did my hemodialysis for not long. I think it would be like 6 months, 6, 7 months. And then it was okay. I had a lot of support at the unit. I met different doctors also that I was never aware of that was here. I met different patients with different insights of what they are going through and different views of things. And hemodialysis was fine. I took a strain on my body. I lost a lot of weight while I was in hemodialysis. And then I was switched over to peritoneal dialysis, which was much better because I could do things that I want to do according to the time that I set aside for my dialysis. And then the peritoneal dialysis I did was also just for a year and a few months. And then we started the process of transplant, but at that time, we had COVID started, so everything was set aside because we couldn't do any testing and operations because of the disease that was out. So that was delayed for about 3 years, 2 or 3 years. There was a delay in the testing. And then once the COVID was under control, we started the testing again. Lucky for me, my friend was still very willing to donate the kidney, and we went through counseling and we did all our testing. And the first thing they asked is she paying you for the kidney? Because we're not allowed to pay for kidneys. And then my friend was like, no. She's very soft-hearted, so she's like, no, I would never take money. And she's much older than me. She's about in her early 40s, so she's got also 2 kids as well. So at that time, the counseling was very intense because I felt very responsible if something were to happen to her. She's got a husband, she's got 2 young kids, she's got a father, she's still got her own family. And some people, they don't understand about organ transplants, like kidney now to be specific, because for them it's either like you're giving your life away to somebody else. So I might survive, but she might not make it through. So that was very intense for me with the counseling because she was very, no, it's fine, I'm going to give it like nonchalant, like that's just something you do every day for people. And it was very tough for me. I had to go through a lot of counseling. I did personal counseling as well outside of the hospital just to get over that and to understand that a friend would do something so big instead of your own family members, close people that you know. So that was also a process to go through with her. And she knows that I had lupus for the time that she met me for all the years. And I just have brief conversations with her just to let her know how it is, what it would be like. And then, like Dr. Barday said, I had the end-stage kidney failure. And then after the transplant, it was more of a struggle. Dr. Barday just asked me earlier on, what do I think? Is it the lupus or the dialysis or after the transplant that has more intense feelings? So I said to her that I think after the transplant, things are more intense because now everything you eat, everything you do, it's what's the creatinine? Is the creatinine fine? What must the creatinine be like? Because that's me. I just asked her when I came here, what's my creatinine of last month's blood results? Because that's just how I constantly live. I just need to know my creatinine is it okay, is it fine? Am I closer to my baseline, which I'm not. I think I've got like a new baseline now.
Yes,
Instead of the one that she mentioned earlier when she introduced me.
Mm.
So I have to live with that also now. So that is a big struggle for me because now I've got a newborn. I need to juggle my health, creatinine, medications. I need to care for her, do all the motherly things, something that I'm not used to because it's my first time. I've got a very good support with my family. And at the hospital also, I'm a very talkative person. I like to share. So they all know if I don't know something, I ask. And it was tough for me also making the decision to have a baby, a planned pregnancy, because what I did is I also asked my friend that donated the kidney to me, how would she feel if I tried to have my own family? And she was very happy for me. She's still very happy. And I just mentioned that I can't give her your name because my cousin has the same name as she has. So I know 2 Natashas already. And then she said, no, she's perfectly happy and satisfied. Said I can go and the doctor. She point and that point. And I was like at the clinic, I was under 10 patients still. So that was like, at that time, that was 15 years ago. So that's like something that is not new to me. And I just said, okay, it's fine. I understand. And then I think because I spoke to her about starting a family, the urge was more there for me because a lot of people told me, no, I've got 4 kids after my transplant and I've got 6 kids. And then the yearning was just there. And I just said to myself, just one is fine. One is fine and then I'm finished. And because I heard you mentioned earlier as well, there was a lady that also said just one, one is enough. And then I thought of myself because that was also my mindset at that time. And I went to the counseling also with the doctor. And there was one, I usually attend on a Wednesday, the transplant clinic, but it was changed to a Monday because of me attending the maternity clinic as well. Dr. Barday, the male one, he was very upset with this other patient. She was 6 months into a pregnancy yet without telling him. And he was like, how could you do this? Not telling us. And I was so afraid. I was sitting outside the receptionist that's working at the clinic. I told him, you're there. I can't ask him, is my creatinine fine for the baby? Because he's very upset. And then he was just going off there, but not at the patient, but to himself and probably one of his staff members that was there. And also just maybe the respect because, there is still humanity in a doctor. Like with the work they do, they just want to keep you safe, keep everything in order. They don't want to lose a patient. So the patient comes first. And after that, I took it a day at a time. Every appointment became a month at a time. Because when you start after the transplant, I think it's every week you come, then every second week, every month, and then after that they see maybe every second month or third month, depending on the condition of the creatinine and all the other bloods that they do. And then I was very skeptical and I asked and I asked and I asked. And then what is the doctor's name with the blonde, the short hair?
I'm not sure, but can I ask you a question? If you had to think of what you found most useful during that journey, you've walked us through the pre-pregnancy and in the pregnancy and post-pregnancy period.
Yeah.
What did you find helped you the most to get through that journey?
Speaking. Like and all the healthcare was there for me, everything I needed. Like if something bothered me, I could call, can I come in? This is not right. Even if it's something that's small, they never turned me away just because I was pregnant to say, no, you need to go to the emergency or you need to go to the maternity. I could still come to my clinic to E13 and tell the doctor, even that is not their expertise, but I know that they at least know something of the maternity or what I'm going through. And I could always come here, they could always speak and just refer me on where to go and what I can do and what I should do. And what they always told me that the stress and anxiety that I feel is putting more pressure on the pregnancy because that would mean my high blood pressure would go up and then preeclampsia and then everything would just fall off each other.
Do you have any regrets?
No, no regrets.
Okay, no, wonderful. Thank you so much for
Thank
sharing
you.
your
Thank you for
story.
listening.
And I'm going to hand over to Bianca now. Robin isn't showing you, but her beautiful daughter is sleeping right next to us after having a nice bottle feed. So thank you so much for sharing such a big part of your life.
Thank you for having
Yeah.
me.
Robin,
Bianca,
thank you for coming and joining us today and sharing your story. I'd like to hand over to Nicola now just to give us a bit of background about what her experience was in kidney transplant and what her experience was in doing this research as well.
Thanks so much, Bianca, and thanks so much, Robin, for your story. That was really wonderful to hear. And yeah, I'm going to share a bit about my story, which is at a very different stage in the life cycle, I guess, and my journey going through this. So I really appreciate Robin's story and all those women who face things that I didn't have to go through, as I'd already had my 3 children prior to requiring a transplant. So This is me 3 days post-transplant, sitting up in hospital, and feeling quite well. So I received a living donor transplant at the age of 44, and I did 9 months on peritoneal dialysis because I lived in the country, and my oldest daughter was doing her final year of high school, and it all just happened to come at the same time. And at that stage, 11 years ago, I would have had to have been down in Sydney for about 3 months at that stage. And I didn't want my daughter doing her most important year at high school while I was down in Sydney for the whole time. So we decided to delay my transplant until after she'd finished her year 12. One of the reasons was really being concerned about the burden. I was really worried about the additional things that were being put on my children already. At that stage, they were 17, 15, and 13. And out of a 12-month period, I was actually away from home doing dialysis training, transplantation, and medical appointments for 15 weeks of 1 year because we lived rurally. And so that was one of my main concerns, and I really related to some of the women in the study who had children and who really shared that they kind of tried to hold everything together and only show how much they were struggling when their children weren't there, and that they were really trying to protect and preserve and not burden additionally their children through that time. And being away from my family for that time kind of changed the dynamics of everything. And in some ways, my children grew up a lot quicker. One of them helped with the cooking a lot more, and they became very independent and helped a lot. One of the things that I really struggled with was my periods because they had never been fantastic, and I had a pre-existing diagnosis of endometriosis and multiple surgeries. And then leading into starting dialysis, obviously I was quite sick, and so I hadn't had one for a long time. And then once I started peritoneal dialysis, having heavy periods that lasted 27 and 28 days, and then I'd have a couple of days gap, and then they would start again, was really confronting. And to get ready for transplant while trying to maintain iron levels and energy and deal with fatigue and cope with those things was quite challenging at the time. And where I lived in a small rural town, we actually didn't have a gynecologist there, so it meant traveling away to go and see them as well, and to try and fit all of that in around peritoneal dialysis and getting ready. But I couldn't maintain my iron levels, so we really had to look at dealing with that with a Mirena, which was fantastic, and really helped going forward in many ways. I guess one of the things that I have struggled, and it resonated with a lot of the women in the interview study, was really around hormonal changes post-transplant, and not knowing what things were actually side effects of my medications, what things were the changing hormone levels, and actually going through menopause quite quickly and a lot earlier than I was expecting to go through it. And so I think they were things that I wasn't expecting, and I certainly wasn't prepared for. And then when I was looking up information about transplant and menopause and managing it and what was okay and what wasn't, it was actually really, really hard to find information and make decisions about how I was best going to deal with those things going forward. I guess, and Robin brought it up about the chubby cheeks, and I certainly have those as well as the side effects of prednisone. And body image was a big one that came up throughout the study with women. And another aspect that came up was really a change in intimacy and close relationships and sexual relationships within women within the study was something discussed. And that was something that I guess a lot of women hadn't really talked about that with other people until we asked them within the study. And we had those conversations. And I guess that's not an easy thing for people to raise or to talk about, the changes and the impacts having an unwell partner has on our relationships with our partners. That was something I found really amazing, that women shared some incredible insights and the changes that went on, and actually expressing a fear that some of their partners felt that they may hurt them or cause them damage or cause problems with them in the transplant, and they didn't want that. And so understanding the dynamics that happen in those relationships was quite fascinating. I guess for me, some of the highlights of doing the study was I was really privileged to be one of the interviewers of the studies, was really around hearing women from different countries where there's actually not transplantation available in their countries. And, here I was thinking things were tough because my transplant centre was 525 kilometres away. But actually hearing the stories of women, actually not having transplant facilities available within their country and traveling to incredible countries like India and having to go overseas and also having to fundraise, having to look at finding money from somewhere to actually fund their living donor transplants in other countries. Excuse me. So the perspectives, I guess one of the highlights for me was really hearing from women all over the world who had very different experiences to me. And I guess one other thing before we go into the last bit was really around vaccinations and the availability of those. And in Australia, we're really lucky to have HPV vaccines happening and rolled out amongst school children. And, we have some of the most amazing rates of vaccination. But those things are not always available in other countries. And some of the side effects that the women and the really horrendous surgeries that people underwent as a result of their HPV was quite confronting, and it was a real privilege that they shared some of the really hard surgeries and hard experiences they had and the big changes within their body due to the virus post-transplant. So I guess the next thing we wanted to talk about, and I guess reminding everybody to have a think about any questions you might like coming up in a little while, is really looking at a big part of the study was really not just going, these are some of the issues, these are the examples, this is what women have gone through, and kind of looking at that across multiple countries. But a big part of this was really around looking at how can we make these things better? What do we need to do, both from a researcher, both from a clinician, but also from a patient perspective? How can we do things that are going to make things better for women going forward? So we came up with a list, which is a starting point, really. And we really looked at some of the domains around this, and it was really around decision making and self-management. And really, one of the big things that we've seen in Australia, particularly amongst Indigenous populations, but also within children, has been around peer mentoring and supporting decisions, and having others who have gone through those journeys and learning from them and really supporting people in how they can help them make decisions better. I think for me, it was really lovely throughout my journey to have other women who'd had a transplant, and we met for a coffee morning and asking them some of those questions that I may not have been able to find answers for. The other things that we had as strategies were included establishing the treatment regimes and the treatment teams are patient-centered in their care provision. And as with what Robin was sharing, the support she had from her team and the talks and discussions with Zibya and the other health professionals was really around, her desires and what was going to be best for her and supporting her through that journey. And the other thing we had was really around increased patient involvement in healthcare design, research and advocacy, such as these events that we're holding these sessions where it's including patients and researchers, and really the advocacy is a really big one going forward. It's how do we advocate to improve access for women? We know the differences are there, but how do we go about actually championing and really putting these issues right at the forefront in our countries and in research? A big one was around education on fertility, pregnancy and family planning. And through a lot of the interviews, a lot of the women, it was around 40 to 50% had said that they'd had no discussions around pregnancy, fertility, or contraception with doctors throughout their process, and so they felt quite confused, and some at different points had been told no, and then that changed. And so really one of the strategies we're looking at is the co-design of multimedia resources for women by women with lived experience, supported by their health professionals, that really look at providing some education and information that's evidence-based on these important issues that are more freely available to be out there in the community. And I think one of the things that has been important is really looking at the local within each country and within hospitals, some of the protocols and guidelines for kidney transplantation recipients like Robin who are pregnant. What is their pathway? How does this work? How do the teams work together? How is that cohesiveness there? Who's taking responsibility for what and when? A really big thing coming through is around access to psychosocial support and mental health support, wrapped up in that as well. And a big one, again, was around the peer mentors and care partners to assist with providing support. And really a big one was around advocating for inclusion of psychologists and mental health care professionals within nephrology care teams and transplantation teams, looking at ongoing support and referral as required. I know within Australia, as a high-income country, we do have a psychologist, I know, at one of the transplant centres, but for a lot of us who aren't at that one, the psychologist appointment is really more about a screening process for transplantation rather than actually being there to support patients and guide them where to go for mental health support. And a big one was around addressing the stigma. And that really came through that within some cultures, that really there is a huge stigma around mental health diagnosis or seeking out psychological support, and really, encouraging patients to talk to their doctors around some of this, but also encouraging doctors to check in with patients around how they're going. Continuity of care was a really big domain that we wanted to encourage, and looking at establishing cross-department meetings and management of kidney transplant patients, so across obstetrics, gynecology, infectious diseases, and mental health as required. And looking at the allied health involvement throughout patient management journeys, so including, not only our dietitians, but also social workers, pharmacies, dietetics, physiotherapy, around continence issues post-transplant, where people have been on dialysis for a while and then they're having full bladders that are working again, but they're unable to actually have bladder control. And I guess fertility and pregnancy counselling was really around shared decision-making and input regarding family planning, contraception, and advocating for inclusion in transplantation pathways for women. So advocating the inclusion of fertility and pregnancy counselling with this. And a big one across a lot of the countries was that really financial support for transplantation access and post-transplantation care is needed, and particularly for the provision of universal health coverage or insurance for transplantation and medication, particularly for those countries where it's currently not available, and that there's huge financial emphasis placed on the families to provide that to assist who gets one and who doesn't. Also looking at local assistance and information in accessing financial support through social workers, and working with stakeholder organisations, including government and charities, to establish grants specifically for women around requiring and receiving transplants. And I know in the Philippines, I spoke to quite a few amazing women who were doing some work within the Philippines Kidney sort of foundation, and looking at establishing more financial support around women and their access of transplant there. So through that, through one of the suggestions, and certainly one of the aims of this study, was to generate a booklet around some of the suggestions and some of the information. And currently through WIT Pillar 3 and the amazing team and an incredible patient advocate, Louise, who is spearheading that, is taking some of this information and taking some of the gaps and generating a booklet and information that's going to be more readily available to people, and being able to share that throughout our networks to increase knowledge and awareness as well. So on that point, I'd just like to move, I guess, to the last slide, which is really to thank all the transplant recipients who shared their stories with us. Some of the stories were just incredibly genuine and honest, and hearing about topics that I hadn't even thought would come up was just incredible. Learning all things about surrogacy in different countries, and just to really value their honesty and trust that they placed in us through sharing their stories was incredible. We'd also like to thank the WIT Pillar 3 and the other teams that supported us in, helping to find women who are prepared to share their story and support us, and particularly TTS for supporting us currently with running this webinar, and everything that's been provided. So with that, I'll hand over back to Bianca and Germaine around questions, and please feel free to pop stuff in the question Q&A or the chat to ask any questions you'd like to. Thank you.
Thank you so much to everybody who shared their time and their experiences with us. The first question is actually for Robin. So the question is, did you receive any support in the decision to only have one child? And if so, what was that support? And was there any information that you think would have been helpful with your decision around pregnancy and motherhood, or any kind of information that you would have liked to get?
Can I go ahead?
Yeah.
That decision that I made was made by myself and my husband, because I also know that the creatinine was going up, like Dr. Barday said. So, excuse me. So my choice was really limited, and I didn't want to put myself and my kidney in that position where it's putting so much strain on the body as well. So the doctors did support me, and they gave me a very good job on making that decision, because there's not a lot of patients that decide to do that, something just to close yourself. So many patients just like go ahead, and I just decided it was best for me and for my health and for my family, just because I was satisfied with the one baby that I was blessed with. So the decision wasn't difficult for me. My mind was already made up during the pregnancy, so I was prepared for that. And the doctors just supported me on that.
I'm so sorry. So during the Caesar, is that when they did the
Yes, they did it during the C-section as well.
total tubal
Yes.
ligation? Okay. And did you feel different about it, or did you?
No.
It was part of your
Yes.
process to come to
Yeah.
this.
And I was very secure in making that decision, because there was a kidney doctor also there, because I heard earlier on, someone mentioned that one of the patients said that she said that you need to get a doctor now because they were there by the new kidney. I don't know if they cut it or if they didn't know how to go around the graft. So I was very pleased to know that there is somebody that knows my history and that is there to guide me, just to be calm while they navigate around the graft, to not injure the graft. So I was very happy.
Thank you. Amazing. There's one question in the Q&A that I think might end up coming back to me, but I'm just going to circulate it to Maleeka and Nicola. So the first was just a thank you for excellent presentations. Lisa works with the Transplant Pregnancy Registry, and she says that she has brochures and data to share. They tried to connect through Facebook, and some people find them, but do we have any suggestions on how to help other women? So if I'm understanding the questions right, you have more brochures and data to share, and the question is, how do we collaborate? Is that correct, Lisa? So if we work on that premise, Nicola and Maleeka, what are your thoughts? I think that that's a great resource to incorporate into WIT, and I'm very tempted to ask Lisa to post her details or her email address if she's willing to, and we can connect you with our WIT Pillar 3. So that would be
Bianca, I can talk to Lisa's thing, because I was recently asked to give a talk to the Transplant Nurses Association, and I used a lot of information from Lisa's transplant pregnancy registry. Another person who works a lot in the pregnancy space in transplant is Shilpa Jessudasan, and I believe that they work quite well together. So when we're working in South Australia, we do mention resources like that, especially considering that we see most of the women who get pregnant in our state, because we've started to make a state-based pregnancy collaborative, so that we've got people who are actually interested in pregnancy, and they can help other nephrologists who don't really want to deal with the pregnancy counselling, the pre-pregnancy counselling, and the teaching. And I know that Shilpa and her team are actually doing some education around that and training the trainer around pregnancy and transplant. So I know that that is happening, and I went to one of their first webinars recently. So I think that probably getting that information out for the transplant pregnancy registry is a good idea, and maybe we can collaborate. And the way of getting that around is to collaborate with other people. And a lot of the other stuff is through ISN and TTS. And I would imagine that you're going to say something about TTS, Bianca.
Yeah, I actually just wanted to, I think it's a great way to collaborate, and there is TTS that is coming up. But before I hand it over to Germaine to advertise, I just had one more question I wanted to ask with the 1 minute that we have left. Either for Nicole or Maleeka, did you notice any differences in women's responses between the high income countries and the low? And was there anything striking to you about that, about the barriers faced?
I'm happy to go first. I guess it was really around the financial aspect, was that particularly the universal health coverage was like the standout, I guess, difference from, and in those countries where there wasn't that, there was a greater issue of financial difficulties that people face to access it. Excuse me. And I guess the other one that was striking to me was really around the psychological support. So the women in the higher income countries more talked about accessing psychological services off their own bat, and it didn't happen through that. Yet some of the patients, more from the lower income countries, it wasn't really raised as an issue of needing that, or talking about it, and not saying that it wasn't there, but I think that the issues were different, and that they may not have had that as accessible as I guess as culturally appropriate to access that or to talk about that within those societies. So yeah, I think Maleeka, did you want to add anything?
Yeah, so I agree, Nikki. I found the biggest discrepancy was the financial and access aspects. And I think one thing that didn't really come out in the paper that I found quite interesting was the limitations in what women were able to get in terms of their healthcare, like how long they could get dialysis, how long it was funded. And also, because our study was right in the middle of COVID, who could get access to vaccinations? I found that really interesting. And there were some people who could not get access to vaccinations. And I found that quite disheartening. And these people were putting forward and having to advocate for themselves to get the transplant population immunized before the general population when vaccinations were available. I thought that was one of the really key issues. And as you said, psychology was also a really, really strongly mentioned one around the counselling of not just the patients, but their families. And I think that support for the families is really, really important, because as you know, when there's somebody, especially a woman, they're often the center of their household, and that impacts the rest of the family.
And I guess just to finish off with one last thing, I think we have to keep in mind access to information and education. So within, high income countries, we have access to Wi-Fi and internet and, resources, sometimes too many accesses. But I think when we're producing our booklets and we're looking at some of these and we're wanting to get this information out to people within lower income countries, trying to do the interviews was really quite complicated, getting people access to internet website and doing all of that. So I think access to information around these services is something we have to really think about, how we get it out and disseminate it to some of the people who need it the most.
Nikki, I
And
think
just-
that's a great question there, because there's a question from Gamanthi asking, is there any international registry for organ transplant patients? And this is exactly about information dissemination. We have organ registries across the world. I think one of the issues and one of the barriers is that none of these registry, and I have to say, certainly from the ANSADA perspective, provide patient-relevant information that can be easily digestible and also disseminated across the globe. And I think this is something that we definitely need to work on. Some of the pregnancy outcomes data are all there. So I think this is crucial that we as clinicians and researchers and people that work within the data field to have access and provide those access for our consumers and our patients.
Great. And just as a closing remark, we have had a comment from Claire Sharp, who's also doing similar qualitative studies for female transplant patient experiences. And she says that the issues resonate with the findings that we had. So I just have posted in the comment block that we'd love to connect her with the WIT Pillar 3. Just from my side, a huge thank you to Maleeka and Nicole, who have been amazing in their perseverance when we were finding people from all over the globe. So thank you for the after-hour work and the Saturday morning work and the looking at all of this data. You have done an amazing job at representing female patients globally. And with that, I'd like to hand over to Germaine to close off the session.
Thank you so much, Bianca. Thank you, Nikki, Maleeka, Zibya, and also Robin for sharing your wonderful journey and all the wonderful work that we're doing from a Pillar 3 perspective and the advocacy that you're shining through the world. I would like to welcome you to 2026 TTS in Sydney. It's going to be a wonderful meeting. We have lots of WIT activity. In particularly, we have a pre-congress that's solely focusing on women's health issues, access to transplantation. But more to that, we have a program, the main program within Sydney, which is not just about clinician or researcher. It is also very much about a patient and consumer facing information for all working and involved within the field of transplantation. So hopefully you can all join, and we welcome you in Sydney. And we also thank you once again for the organizer, for Jen, and also from the TTS team waking up early in the morning for us. And thank you once again, and we'd like to close and happy to chat outside this forum. Flick us an email, Bianca, us, Nick, Maleeka, all of us. And good night. Have a lovely day. And thank you once again.